Test.
Oh, there it is. Well, test. Okay. Good now. Okay, so we covered the background on Jacob. So now in his psychiatric med management visit, Jacob is reporting new constant worry about his health status. He's very afraid he's going to have another heart attack and die. He thinks about it all of the time, and it's hard for him to concentrate at work because he keeps thinking about this. What other information should you be collecting from Jacob before starting to come up with an assessment? Give me some ideas. What other medications does he take? I heard history. What kind of history? Past medical history? Absolutely. Family history? Definitely. What else? Substance use, definitely. Okay, so the other things that you want to ask is you really want to understand about his current symptoms. So not just what we think could be contributing, but what his real current symptoms are. So how long has this been going on? Have you ever had anxiety before your recent heart attack? How are you sleeping? How's your mood been? Because he's here for depression, right? So we want to make sure we're checking in with him to see how his depression, if it's still in remission. Has he been finding himself agitated or on edge? And what else does he worry about? Because we're also trying to go through that checklist of the DSM criteria and see is he actually meeting criteria for generalized anxiety disorder. What are the main neurotransmitters that are involved in anxiety? Norepinephrine, yep. Serotonin, One more. And GABA, yep. Those three. Okay, so treatment approaches for generalized anxiety disorder. So again, we have to consider the differential diagnosis because people can feel anxious symptoms for a variety of different reasons. It could be because of a medical illness that they have. And I'm not going to go through these one by one. You can just see the list on the slide. They could have other psychiatric illnesses that are contributing. And, of course, there could be medications or substances that are causing their anxiety symptoms, which there are a ton. So, now what other information you want to get? We talked about the medical history and the family history, so this is kind of more what I was going at with this slide. Anything else? One more thing. What medications is he taking? Right. So medication list, family social history, and part of social history would be a lot of that substance use we want to get after. And then it would also be good for us to obtain a TSH, which is the thyroid stimulating hormone, to make sure that his thyroid's working well. Because when people have hyperthyroidism, they can actually have a lot of these anxious symptoms. So we find out all of Jacob's history. So we know a bit about his medical history, right? He's got coronary artery disease because he had a heart attack 7 months ago. He has diabetes. He has hypothyroidism. And his major depression is in remission. We can see his med list here. His labs were all within normal limits, including his thyroid hormone. For his family history, his mother and father were elderly, but they're still doing well. However, he has a sister who has obsessive-compulsive disorder. In his social history, he smokes marijuana every day. He has 1 to 2 12-ounce beers during Pats games, and he drinks 10 cups of coffee a day. So, what factors could be contributing to Jacob's anxiety? Do we think 10 cups of coffee a day, sister with OCD, having elderly parents, having a recent MI, daily marijuana use, hypothyroidism, or that he takes levothyroxine, which is the medication to help with hypothyroidism? And sorry, I messed up the responses again, so I realize that there's probably only 4 options on your thing. Okay. So, 10 cups of coffee a day, definitely. Sister with OCD, definitely, because it's family history of another psychiatric disorder and one that tends to also have anxious features. Having a recent heart attack could be because of comorbidities, could be causing him to not only have anxious symptoms, but the fact that he's worried about the fact that he had a heart attack would be contributing. And the daily marijuana use definitely is a factor. Levothyroxine, which I didn't include as an answer here, could be a factor if his TSH was abnormal. So like if he was taking way too much levothyroxine, that can actually cause symptoms of anxiety and feel like increased metabolism and stuff. And so you'll learn about that a lot more when you get to the thyroid stuff, but that's just kind of keep that in the back of your mind, that if he were taking super high doses of his levothyroxine, he might also be feeling those symptoms. But because we know that his TSH was normal, he's not taking those high doses, so we shouldn't expect to see those symptoms. Okay, great. So back to treatment approach. There are several guidelines on how to treat generalized anxiety disorder, but they all kind of say different things, and they don't really have any one way of approaching it to say that, like, this is the absolute way that anxiety should always be treated. So we want to make sure that we're really keeping the patient in mind. People with anxiety disorders present in all sorts of different ways, and there's a whole bunch of things that we need to consider, and so that's this list here. So how severe are their symptoms and how long have they been going on? Is this person completely debilitated by their symptoms, or are they still being able to function somewhat? How old are they? What other kind of comorbidities do they have? Because that might affect what treatment we choose. Concomitant medications might also affect what treatment we choose if we're thinking about drug interactions. Potential adverse effects to anxiolytics that they may have experienced before that they don't want to experience, and so they would want to avoid certain anxiolytics. History of prior response to a treatment, which is another consideration that we remember from the depression lecture, where if somebody's had a positive response to a certain medication at one point in their life, they're likely to have another positive response again. Patient preference, because that also factors in just like it did in the depression lecture. And of course, medication costs and access. So the goal of treatment for generalized anxiety disorder is complete remission, and so that's having no symptoms whatsoever. The initial treatment option, so if somebody says they don't really want to, or what do they start, how do they begin addressing their anxiety, we can think about psychotherapy. Just like with depression, there's cognitive behavioral therapy for generalized anxiety disorder, and it's specific to generalized anxiety disorder, helping people think and behave differently when in response to the things that make them anxious. And then there's also interpersonal therapy, which again is that more talk therapy. There's also pharmacotherapy, which looks very similar to the first-line treatments for major depressive disorder, so SSRIs and SNRIs. Bupropion is not a first-line therapy. It's actually not indicated for GAD at all. And the reason for that is that bupropion, because it's so activating, if you guys remember, I listed off those 3 activating drugs yesterday. Bupropion is so activating that people tend to say that it makes them particularly more anxious when they start, and their symptoms get significantly worse. So we tend to avoid bupropion for treating anxiety. In practice, I have to always give this disclaimer that I have seen people using bupropion and people reporting that it helps with anxiety, but this is something that we don't tend to teach because that's not what the norm would be expected for bupropion. Okay, so first line, SSRIs, SNRIs, and mirtazapine. Now, I think I got maybe 1 or 2 questions about this yesterday when you guys were filling out the drug charts, or I'm sorry, the worksheets. So for the lowest effective dose, the same is true for generalized anxiety disorder as it is for major depressive disorder. The lowest effective doses are still the ones that I have posted on that Clinical Pearls document. But with generalized anxiety disorder, you tend to want to start off at a lower dose. And I have this maybe coming up in a minute. But you tend to want to start off at a lower dose with the medications that you're going to start with, specifically the SSRIs and the SNRIs. And the reason for that is you can get what's called jitteriness syndrome, and people start to feel a little bit amped up when they're started on too high of a dose, and maybe when they have too much of that serotonin getting kicked off too soon. They need to get used to it for about 1 to 2 weeks, and then you can increase the dose to that minimally effective dose. So, pharmacotherapy, psychotherapy, or a combination of the two. For an adequate antidepressant response, which is the same as it is for major depressive disorder, a 50% reduction in symptoms, it should take somewhere between 4 and 12 weeks. So where major depressive disorder, we expected a full response by 8 weeks. If there's no response, then we definitely want to change the drug, add something on, do something different. Whereas with anxiety disorder, we tend to want to wait a little bit longer because sometimes the symptoms of anxiety disorder could take a little bit longer to start remitting. You'll then, if you achieve that adequate response, you'll continue at the same dose for somewhere between 9 to 12 months, and then you'll reevaluate every 1 to 3 months within that time frame. Generally, we say, so I said 9 to 12 months, somewhere at least 9 months you want to stay on antidepressant treatment if antidepressant treatment is what's chosen as the treatment of choice, because if you stop any sooner, you're really likely to relapse. And so somewhere between 9 and 12 months, you want to stay on treatment for at least that long. And then after that, if the patient says they don't want to take it anymore, they're sick of taking a pill every day, you can then have that conversation with the patient to plan coming off of it. So if somebody has a partial response, so they didn't have that nice 50% reduction or more in symptoms, it's really not clear based on the literature what to do next. We can do a variety of things. We can increase the dose if it's not already been optimized. We can augment, so we can add something else on, or we can totally switch treatment. And full disclosure, we don't know what happens with, like, we can only do patient by patient, case by case scenario and see, okay, well, one of these things didn't work, so let's try another one. Or I think if we add, if you've been on sertraline and that's sort of maybe giving you some sort of symptom benefit, but it really doesn't feel that much better and you're still having a lot of trouble sleeping, maybe we can try adding on mirtazapine to see if you can get some sleep benefit and then maybe get a little bit more bang for our buck there with the antidepressant anti-anxiety effect. But it's not clear what to do next. So this is just for your information to kind of have an appreciation for the fact that we have these first-line options, and then after that, we kind of wing it from there on out. So if the symptoms persist after an adequate antidepressant trial, which again, like I said, is a little bit longer for GAD, so somewhere between 8 and 12 weeks, you could switch to an alternative first-line option. So if you went from maybe an SSRI to an SNRI, that would be appropriate. Or you could augment the first antidepressant with something like an antipsychotic, a benzodiazepine, an antihistamine, buspirone, or a gabapentinoid like gabapentin or pregabalin. So that's what that list is at the bottom of the slides. And then for non-pharm treatment, like we talked about, there's cognitive behavioral therapy, interpersonal therapy. Supportive psychotherapy is kind of the same thing as IPT. We also do a lot with patients with generalized anxiety disorder and other types of anxiety disorder. We really try to encourage them to embrace relaxation methods and do a lot of training and try to get them on board with finding ways to induce their relaxation response. We also, this is supposed to say meditation, not medication. So we do a lot of work with helping patients learn how to meditate and try to get into that mindfulness and, of course, mindfulness practice. So for pharmacotherapy, we have, again, another group of different medication classes. We'll start with just the SSRIs and the SNRIs. I won't go into major detail there because you have all of those worksheets to really help guide you. The dosing is pretty much the same as it is for major depressive disorder and GAD. Just remember that you start off at a lower dose with GAD. And everything else, side effects, all of that stuff is all the same. So the only things are just to kind of have a general understanding that there are some of the agents have specific FDA indications for GAD. So the SSRIs are escitalopram, paroxetine, and sertraline, and the SNRIs are duloxetine and venlafaxine. However, if you were to prescribe another one of those agents, so if you were to try fluoxetine, for example, that should also work for GAD. And like I said, best to start with maybe half of the minimally effective dose to avoid the jitteriness syndrome. And so what that looks like is actually that the person has worsened anxiety symptoms, more agitation, more irritability when they start the antidepressant. But just because you're starting at that low dose doesn't mean you want to stay at that low dose. And so you really want to make sure you're not afraid to keep titrating up until you find that the dose is actually effective for the patient. So benzodiazepines. So you can use some of the information that we're learning about benzodiazepines now to remember some of the features that you may want to remember for the insomnia lecture. But most of this stuff applies, most of the stuff for benzodiazepines kind of applies in all situations. So benzodiazepines, if they're being used for anxiety, should only ever be used for very acute treatment, very short periods of time. So like we talked about in insomnia, they should only be used for a maximum of like 10 days. In GAD, same thing. They really shouldn't be used much longer than 2 weeks at most. They provide rapid relief of anxiety symptoms. This is the part that's really tricky about benzodiazepines. When people take them, anxiety symptoms go away, and people feel better, and it's like right away. It's within like somewhere between 15 to 45 minutes. And like they don't have anxiety symptoms anymore. A lot of times that's because they're sleeping, because benzodiazepines make them sleepy, and so they just don't care about anything anymore. But other times people aren't. They can tolerate them, they can stay awake, and they just don't have the anxiety symptoms. The problem comes in when we talk about all of the adverse effects that come along with benzos. So 2 to 3 weeks max, I say 2 weeks max. And it's thought to be, a lot of psychiatrists will prescribe benzos with the thought in mind of this is just a bridge. until maybe the SSRI kicks in, because we know that it takes a while for SSRIs and SNRIs to actually start working and have effect. And so sometimes we can bridge the person if they're having really severe anxiety symptoms with a benzo with the intent that the benzo is definitely going to come off. Problem is, once people take a benzo and they realize that it instantly takes away their anxiety symptoms, they never want to stop it. And so it can be really hard to get people off of benzos. So, dependence and misuse are one of the major reasons we don't recommend long-term use. And the fact that if they do abruptly stop after about a month of continuous use, they're likely to have some type of dangerous withdrawal that can include seizures and death. Other thing to remember for benzos is that you're not getting any effect whatsoever for depression. So if somebody has GAD with major depressive disorder, or somebody has an anxious depression, or has some low mood that's kind of accommodating their anxiety, benzos are not going to touch that mood at all, and if anything, might make the mood worse because they're known as depressants. So how do benzos actually work in the brain? So I talked about this a little bit in the anxiety or in the insomnia lecture, but they non-specifically bind kind of all of the GABA subunits of the GABA-A receptor. Alpha subunits of the GABA-A receptor. So it causes a receptor change and it increases the GABA receptor activity. So what happens is you get this chlorine influx when it's activated that causes a hyperpolarization of the cell. And so when cells are hyperpolarized, it's harder for the cells to actually cause an action potential and fire off some sort of effect. So when you have decreased action potentials, this is kind of why GABA is the inhibitory neurotransmitter of the brain, because GABA works specifically through this way. And so anything that activates GABA, like benzos and alcohol, all do the same thing. So you have reduced action potentials, so everything gets slowed down. And then you see sedation or sleepiness, anxiolysis, so reduction of anxiety, amnesia, so forgetfulness, and memory impairment, relaxed muscles, and then they stop seizures. So some of these slides, I have a bunch of information. I didn't want to make you guys do a whole other set of worksheets, so I just kind of included these. I'm not going to go through them one by one, but plan to have an understanding of the doses that are boxed in yellow. So that's for alprazolam, clonazepam, diazepam, and lorazepam. Those are the four most common benzos that we see. And then for pharmacokinetics, plan to know the stuff that I have highlighted in yellow here. So the agent, which is just alprazolam, that's associated with really terrible rebound anxiety. People can even have what they call interdose rebound symptoms. So sometimes people will take Xanax like 3 or 4 times a day. Alprazolam is Xanax. So they'll take it 3 or 4 times a day. And if they took it in the morning, they'll start to already have rebound anxiety symptoms like 4 or 6 hours later because they're already getting that rebound coming up. And then know that the lot drugs, lorazepam, oxazepam, and temazepam, which I have on another slide, are better for people with hepatic impairment because they're not metabolized through the liver. They're not cleared through the liver. So for drug-drug interactions, except for those lot agents, LOT, the other benzos mostly are metabolized through cytochrome P450 3A4. So you would expect that inhibitors of 3A4 would increase the concentration and inducers would decrease the concentration of those benzos. Like I said, the lot drugs, lorazepam, oxazepam, and temazepam, are not hepatically metabolized, and so they don't have very many PK interactions. And then you would expect for pharmacodynamic interactions, anything else that slows down the system or slows down the brain. So other CNS depressants are going to have an additive sedative effect. It can be really dangerous if you combine them with alcohol or opiates because all of those things will slow down the respiratory drive and could cause an overdose and death. But you could also imagine anything else that slows down the brain. So antipsychotics, antihistamines, anticonvulsants, and so on and so forth. So for adverse effects, there are a whole bunch of them. I don't want to go through them all independently other than just knowing that you have a variety of adverse drug reactions and you can monitor them in various ways. And you really want to make sure, if you're starting a patient on a benzo, to give them the education that they need to make sure that they're not going to end up being kind of victim to one of these side effects. One of the big things that I always tell people is if we're doing like a bridge therapy, so we're going to like give somebody a 10-day supply of clonazepam, it's really telling them, like, this will stop at day 10, and we're going to wait for the other stuff to kick in. This is really only intended to be a bridge, and I'm not going to prescribe it to you after this. So that the patient really knows. And then when they say, well, why? They're like, well, you can get addicted, and it can cause a whole bunch of other really bad things. And so we don't want to see that happen to you, so I'm only going to give you 10 days or 2 weeks maybe. Most of the time, patients really appreciate that honesty, and once you're just open and honest with them, they're more likely to be like, okay, yeah. And sometimes they'll just be like, don't even give it to me. Like, I don't even want to start it if there's a risk of being addicted. So some concerns, though, like I said, really quickly on, people can already start to develop dependence, 2 to 4 weeks. They'll have tolerance, and so after maybe like a month or two, people will say, I need to increase my dose. It's been a month, things were going well, everything was my anxiety was just fine, and then now all of a sudden it's not, that same dose isn't working anymore. I want to increase my dose. And then because of the physical dependence and tolerance, you'll see withdrawal symptoms upon abrupt discontinuation. Important to know that all benzodiazepines have the potential for addiction. So this is not, even if they've like done some studies and showed that, well, 6 months out, the people didn't develop addiction in a randomized controlled trial. They all work the exact same way in the brain. They just last a little bit longer depending on the way that they absorb into certain tissues and stuff. So they all have the potential for addiction. Sure, not everybody gets addicted to benzos, but the risk is definitely real, and the other side effects, most of the time people are not willing to kind of let the side effects outweigh, or most people think that the side effects outweigh potential benefits. We talked about how it's difficult to taper, and it's mostly because most people think that, or a lot of people will think that benzos are the only things that actually help their anxiety, because it's something that you take it and within 15 to 30 or 45 minutes, you feel the symptoms go away immediately. Whereas with SSRIs and SNRIs, it doesn't work that quickly. And so it's really hard for people to kind of come to terms with the fact that they kind of need to be a little bit patient and wait for the other stuff to kick in. Any questions about benzos? Yeah. Yeah, and so that's when things come in, like, especially people who, so the question is, what if people are getting it on an as-needed basis? Maybe they only have 10 pills and it's supposed to last them a month. So that tends to come in, especially like with panic, when people have panic attacks. Sometimes people will take a benzo and it calms their panic attack and things get better, and then they don't use it again for like 3 months. That definitely is an appropriate use of benzos. I think I told you guys this during the anxiety lecture, I'm anti-benzo. So I'm somebody of the thought that people really need to learn how to experience anxiety. I can actually I can be full disclosure, I have panic attacks. I just learned this in the last 6 weeks. And my doctor offered me benzos, and I said, nope. I need to learn how to deal with anxiety. I need to learn, when those symptoms come up, I have to teach my brain, this is okay. This is not an unsafe situation. This is going to be just fine. So that's what I try to tell patients is, I know what you're going through. And, it's going to be okay. You're actually in a safe place. And the more that we do to help patients numb out, which is what benzos do, like I told you during the anxiety lecture, taking a benzo is just like taking a shot of tequila. So the more that we help patients numb out, the more that we're teaching them that the anxiety symptoms are unsafe and that it's not okay for them to feel those symptoms. And we don't want to teach that. We need to teach them that actually this world is generally mostly a safe place. And so that's my soapbox there, and I'll try to get off of it now. So we talked about withdrawal symptoms during the insomnia lecture. They're listed here. People just tend to feel much, much worse when they're abruptly stopped. And sometimes even when they're slowly tapered, they'll start to feel much worse. Lots of risk factors for withdrawal. If the medication has a shorter half-life, so that's looking at this kind of faint gray line here. If a medication has a shorter half-life, you'll see much more severe withdrawal, but it lasts a shorter period of time. Whereas the longer medication half-lives, the withdrawal tends to last quite a bit longer, but doesn't peak so severely. People on high doses will have worse risks or worse withdrawal who've been using it longer. Anybody who has a history of seizures, of course, abrupt discontinuation. but then also people with electrolyte abnormalities, because that could alter our seizure threshold, and so that can increase our risk of having a seizure, or abrupt discontinuation of any other agents that alter the seizure threshold, again, increasing the risk for somebody having a seizure. So when it comes to tapers, you have to taper, like you can't just stop a benzo. Even if it's a really long-acting benzo, it's really important to work with the patient and get them on board with saying, okay, I'm going to stop this medication. It might take us 6 months to actually get off of it, but by gosh, I'm going to get off of it. So there is no optimal duration. There's no like ideal period to taper a benzo. In general, they say you could reduce by about a quarter every 1 to 2 weeks until you get to half of the original dose, and then you decrease by 10% every week thereafter. So, like I said, this could take 6 months. Very long tapers are really common, and that's really in order to help continue your good rapport that you might have with the patient. You don't want to say, like, I'm going to make you experience this horrible, difficult withdrawal and just, like, let you go free. Instead, you can say, we're going to work together on this, and we're going to do this over the next 2 to 6 months, and I'm really going to be there to support you and help you along this way of getting off of this medication. Once the dose gets down really low, you can consider even everyday dosing if it's too hard for the patient to completely stop. And they always recommend keeping the nighttime dose, especially if the patient has trouble sleeping, just until the patient's ready to start coming off of that. So you'll get, if they're taking it 3 times a day, you'll slowly decrease each of the 3 times a day doses. But then once you get down to like the very end and they're only taking it once a day, typically that once a day dose is their nighttime dose. And then you might reduce that to every other night, maybe every 3rd night, and you'll just keep kind of going down until they're totally off. So back to Jacob. You referred Jacob for CBT to target his anxiety and panic symptoms, and you plan to visit with him again after 16 weeks of therapy, and you tell him to call if he has any concerns in the interim. Jacob ends up attending 3 CBT sessions before he has a PCP visit. At that PCP visit, he's prescribed lorazepam 1 milligram by mouth 4 times a day. You don't find this out until your 4-month follow-up visit, and Jacob says he didn't call because the lorazepam's been helping so much, and he asked you to increase the dose because it was so helpful. So what would be the most appropriate course of action at this time? Would you, hold on a second. Would you continue lorazepam at 1 milligram 4 times a day? Would you start lorazepam taper? Would you change lorazepam to 1 milligram 4 times a day as needed? Would you stop lorazepam because Jacob is showing signs of addiction? Or would you increase lorazepam to 1 to 2 milligrams by mouth 4 times a day? Okay. Oh, nice. Everybody. Yes, start lorazepam taper. I agree. Okay, so you've convinced Jacob to actually get on, do the taper, and then re-engage in CBT. How would you schedule his taper? Would you, A, decrease by 25% every 2 weeks, decrease by 25% every week until a total daily dose of 2 milligrams, then decrease by 10% each week? Would you decrease by 75% each week until at half of the original dose, and then decrease by 25% each week? Would you decrease by 10% each week until at half of the original dose, and then decrease by 25% each week? Okay, great. So some of the class said decrease by 10% each week, and so this is probably just flipped. So the recommendation is B, which is you go by about a quarter each week until you get to half of the original dose, and then after that you go down by 10% each week. And remember, the original dose was 4 milligrams a day, so 2 milligrams is half. Okay, so on to buspirone. So buspirone's interesting. It's considered an, oh, sorry. Oh. If he took it for 10 days, 4 times a day, I would definitely taper. I wouldn't taper for like a really long time, but I would decrease to, I would probably go down to 3 milligrams. I would do like 1 milligram 3 times a day for like 2 or 3 days. 2 times a day for 2 or 3 days, and then once a day, and then off. Pretty much, yeah. And it depends. Remember, the list of the withdrawal factors, it depends on a variety of things. And so one of those things is the dose. And so 4 milligrams of lorazepam every single day is a hefty dose. And so that's enough to where the person's definitely going to have developed a tolerance and or dependence already. And so you'd want to taper from there. I would have added another agent. So this example is where the treater is really trying to get the person engaged in CBT, but I would have definitely added something like an SSRI and then said also do CBT to try to get that going. Yeah, but either one is not necessarily wrong. It's just it kind of depends on. Again, remember this is a patient-provider case-by-case scenario way to choose. Any other questions on that? Okay. So, buspirone is considered an anxiolytic. It's not considered an antidepressant. However, it has nothing to do with the GABAergic system. So it doesn't have any anticonvulsant effects, muscle relaxant effects, hypnotic or motor, like movement effects. We don't see dependence on buspirone like the same way we see it with benzodiazepines. It's more similar to SSRIs and SNRIs in that it does affect serotonin. So you could see some physical dependence in the same way that you would see that with an SSRI or an SNRI, but not nearly in the same way that we would expect to see with benzos. So buspirone is considered second line because the reports of efficacy are not amazing. And there's the delayed onset of effect. Like I said, because it goes through serotonin, it's going to work kind of similarly to SSRIs and SNRIs. So there's going to be that delayed onset. And then the other thing is that the daily dosing regimen kind of stinks. It's somewhere between 2 and 3 times a day that you have to take it, whereas you can take an SSRI once a day and be just fine. So the mechanism of action, like I said, it's not very well understood, but it has no effect on the GABAergic system at all. And there's supposed to be some sort of partial agonist activity at the serotonin 1A presynaptic receptors. So you start off with twice-a-day dosing, and then you end up somewhere between 15 milligrams to 60 milligrams divided. Most of the time that looks like 20 milligrams 3 times a day. After an oral dose, buspirone gets rapidly absorbed and undergoes first-pass metabolism. The half-life is pretty short, only 2.5 hours, so you have to have that frequent dosing throughout the day. Common effects are things like are pretty mild: dizziness, nausea, headaches. For drug-drug interactions, there have been some reports of people having increased blood pressure on buspirone, specifically if they're taking an MAOI or recently after an MAOI. Remember, one of the big risks with MAOIs is hypertensive urgency if it's combined with the wrong thing, and so buspirone is considered one of those things you would want to avoid. And then you can also potentially get serotonin syndrome if buspirone is combined with another serotonergic agent because it works on the serotonin syndrome or the serotonin system itself. Concurrent use of 3A4 inhibitors might increase levels of buspirone, and inducers might decrease buspirone levels quite significantly. So on to hydroxyzine. So hydroxyzine has been studied, and they have found some efficacy for relatively short-term use, up to about 12 weeks. This is also considered second line because it has pretty extensive side effect profile, and it doesn't work very well for, this is another one of those agents that has no effect for something like depression. So if somebody has depression combined with anxiety, hydroxyzine is not going to touch the depression at all. It works because it's a histamine agonist. So it kind of works similarly to like antagonist. So it's just an antihistamine. It's a prescription strength antihistamine. So it's just like Benadryl. So it just makes people sleepy. And this is another one of those things. So I don't really like histamine a lot because I feel like it's kind of similar to just doing something like benzodiazepine. You're just making somebody sleepy and trying to numb out their symptoms, as opposed to helping them to understand that their symptoms aren't actually unsafe and that they need to learn to experience those symptoms and then move on. So that being said, a lot of people use it. We see it pretty often. And so the dosing is somewhere around 25 milligrams twice a day. And you can increase up to 4 times a day. It does get hepatically cleared, and you need to reduce the dose in liver impairment. I don't want to go too much into the details with hydroxyzine, other than definitely not for PK. For adverse effects, because it's an antihistaminergic agent, you're going to see all of the anticholinergic and antihistaminergic effects. You would expect to see combined additive CNS depression if you have it taken with another CNS depressant. So with alcohol and other sedating drugs, we would see more sedation. And then you'd also have additive anticholinergic effects if you combined it with another anticholinergic agent. So that's it for hydroxyzine. Any questions on that one? Okay. So for gabapentinoids, so this is referring to gabapentin and pregabalin. These are not FDA approved, and they're not first-line options. These are like after people have maybe even tried hydroxyzine and thought that that didn't work very well. Gabapentinoids have similar action to benzodiazepines, but for some reason they're thought to be a little bit less risky. It's not that they are actively binding a certain subunit of the GABA A receptors. It's that they're in the brain pharmacologically looking very similar to the GABA molecule itself. So they activate the GABA receptor by looking just like GABA. So they do that same kind of cascade of effects as we saw for the benzodiazepines and how GABA works in the brain. It's a very similar thing. And so with gabapentinoids, we do see anxiolysis, we do see sedation, we see some muscle, like not really muscle relaxant effects, but we definitely see, we know that gabapentinoids are used for neuropathic pain, and so you see a lot of the reduced nerve firing when we start gabapentinoids. And they're also used, gabapentin was originally used as an anti-epileptic medication, and so they are anti-seizure medications as well. So both of them are renally eliminated, and so you have to reduce the dose if the creatinine clearance is less than 50. There are lots of adverse effects, most of them relating to the fact that they are CNS depressants. And you should taper the dose on discontinuation. Usually people get up to pretty high doses of these medications, and they get kind of dependent on them, and because they're anti-seizure medications, there's a little bit of a risk of altering the seizure threshold, and so we should decrease the dose. That being said, I've seen a lot of patients on gabapentin. I've seen a lot of patients kind of abruptly stop and say that it was just fine. I've heard patients with substance use disorders messing with gabapentin and having very terrible withdrawal symptoms, but I don't know the doses that they're taking. I've heard of them taking like grams and grams a day, so I'm not very sure really what the story is there when it comes to gabapentin withdrawal. But that being said, there is some risk. So there is some risk of addiction when it comes to gabapentin, but we tend to see it more so in patients who are addicted to a lot of other substances, especially opioids. We don't see it as much in people who have addiction to alcohol, and that's pretty much it. So for the antipsychotics, these are just a couple quick points about antipsychotics. I'm not going to get into the details here until we get to the psychosis lecture. But we do tend to see quite a few second-generation antipsychotics being used in generalized anxiety disorder, especially the sedating second-generation antipsychotics. Quetiapine is a really common one, with very low doses used maybe a couple times as needed per day. There is little to maybe even no evidence for using antipsychotics as monotherapy without any other agent. You could consider them as like an add-on to maybe an antidepressant if somebody still has symptoms and they're still very activated and agitated throughout the day, but they maybe have gotten some benefit from an antidepressant and you want to add something else on, you could add on like a low-dose antipsychotic. But because the antipsychotics have so many adverse effects, which you'll learn a whole bunch about when we get to that lecture, we really try to avoid them in patients. And again, with the antipsychotics, I think a lot of it is more getting after the sedative effect and trying to numb out the feelings of anxiety. So I think that it's not really it's definitely not a first-line agent and shouldn't be one of the first thoughts that people have in order to reduce anxiety symptoms. So back to Jacob. 1 year later, you see him again for med management. He's been doing well in the interim with periodic phone check-ins. Today he tells you his anxiety is back again. He states he's been trying to utilize the techniques he learned in CBT, but they aren't working. So you finally decide to start an antidepressant. You start sertraline. You do 25 milligrams daily, and then you tell him to increase by 25 milligrams each week until he gets up to 100 milligrams daily. When would be the best time to follow up with Jacob to evaluate his response to sertraline? 1, 2, 4, or 8 weeks? Okay. Ooh, we're split. Okay. So for those of you who thought 8 weeks, can you tell us a little bit why? Gotcha. That makes sense. So you're saying by 4 weeks you should, or by 8 weeks you should expect to see some sort of effect, and we're trying to get after that effective dose, and so something should happen there. Okay. What about people who said 4 weeks? Oh, so like checking in earlier because maybe you don't even need to go, like if they've already started to see some symptom improvement, maybe you don't need to increase the dose that much further. Okay, that's another thought. Any other thoughts? What about 2 weeks? To kind of keep them engaged. Yep. So I said 2 for a combination of some of those ideas. So I agree with really wanting to keep them engaged. There's some evidence to say, I feel like I should have said this yesterday, but it goes for both. So with depression and anxiety, there's this thing called care management, depression care management and anxiety care management. And that's a whole model that you can look up on PubMed, and there's a whole bunch of published literature about it. But what it talks about is if we have close follow-up with people with depression and anxiety, that's every 2 weeks for a period of time, about 2 to 3 months, then they actually are more likely to do better. So it keeps them engaged, and then it also helps us know, well, did they have a side effect? Because we don't want to wait 8 weeks to see if somebody had a side effect and they stopped taking it on week 1. We want to know that much earlier on. It also helps us know if they're starting to show any symptoms of, or any signs of improvement. When it comes to, I like the thought of, well, maybe you don't have to go all the way up to 100 milligrams a day. Maybe you can do just 50. So with some of these medications, I like to think of having certain target doses. And I'm not going to ask you guys to know those. But just for your own kind of like general reference, with sertraline, I think of the target dose as 100 milligrams a day. A lot of people are on only 50. And if that works for them, that's great. But 50 milligrams a day of sertraline is not a very robust dose. The maximum dose of sertraline is 200. So there's a lot of room in there for titration. So I tend to think about somewhere around 100 for sertraline. But like I said, that's really good thought to think about while trying to go after the lowest effective dose. And there's different schools of thought about that with psychiatry. Okay, so why don't we take a break and get started again at 9:25, and we'll do PTSD. Get back and start it again. I had one other announcement to make that I forgot to do at the beginning of class. Blackboard questions. So thank you to the people who have submitted the Blackboard questions so far. For all of you, I think that you should subscribe to those because I've been giving answers to the worksheets. And so if you really are having a tough time with some of the questions on the worksheets and it's like not really clear what I was going after, definitely go to Blackboard and see what other people have been asking questions on and post your own questions. You can just kind of like type them just as the other people have been typing them, and it's been working out pretty well. For those of you who I've responded to, has that gone okay? Okay, great. Any other questions or questions about the worksheets or like how this is all going to come together with depression and anxiety and all of these meds coming together? Okay, cool. So next we'll talk about post-traumatic stress disorder. So this diagnosis is kind of near and dear to me because I worked in the VA for 2 years and I saw a lot of patients with PTSD. And now I actually work with a ton of patients with civilian PTSD, totally unrelated to military service or anything like that. And it's amazing how debilitating it is for people. And so and just how commonly people get misdiagnosed with other things when they actually have PTSD. So I think I tried to tap into that a little bit here in this lecture, but for the most part, you guys don't have to be experts on this stuff. This is just really trying to get you guys to have an appreciation for the fact that there's another psychiatric disorder that's actually really quite common that a lot of people don't think is a lot of people kind of misdiagnose it as just depression or depression and anxiety, when in fact if we dig back and find out that there's a real trauma that somebody had, that depression and anxiety is actually symptoms of their PTSD, and maybe we've been mistreating it all along. So the most of the learning objectives we covered in the pre-lecture. It was just, like I said, it was really quick and just to try to get you guys to understand a little bit about post-traumatic stress disorder. And then this part of the lecture is supposed to be focused more on what do we do for post-traumatic stress disorder and how do we approach people and approach treatment options. So to get started and think about some of the pre-lecture stuff, I want to go through a little exercise of having you guys tell me which criteria fits the symptom. So when somebody, and so if you remember, there were the criteria A through E. And so what I'm going to do is read off somebody quoting something, or somebody saying something about symptoms that they're having, and I want you to tell me if it's criteria somewhere between A through E. So somebody says, it was like I was there, I could smell it, I could taste the sand, I felt trapped. All the cars, couldn't get off the freeway, I started speeding. What criterion is that? Maybe. What else? What other people think? So what is criterion A? That's the traumatic event, right? Okay, why is it not criterion A? What were you saying? You're saying. Yeah, so why is it criterion B? It's re-experiencing symptoms. Yep, it's a flashback. And so flashbacks are the re-experiencing symptoms, the intrusive symptoms. So criterion A would be the person actually giving you their trauma, like the thing that they experienced and whatever it was about that stuck with them and now has caused them all of these symptoms moving forward. Okay. The littlest thing sets me off. Stupid stuff. Things that shouldn't make me mad. What's that? E? Mm-hmm. So that's the hyperarousal. I put that away a long time ago. Don't go there. I don't watch war movies, the news, nothing. Someone asks me about Nam and I walk away. C. Why is that C? Avoiding. Yep. What happened to me is all my fault. I shouldn't have drank so much. I shouldn't have worn such revealing clothing. What he did was my fault. D. Why is it D? It's that guilt and shame. So the negative cognition and mood. Last one, I can't go anywhere and feel relaxed. I'm always scanning. I won't go to the grocery store anymore because I can't take it. There's a couple. It's tricky. I heard E, which is true, and C. So it's avoiding and the hyperarousal. Okay, so we have a patient case. We have Dana. She's a 30-year-old female with a history of major depressive disorder. Today is her 4th visit with you for psychiatric med management. You ask Dana what she does for fun, and she tells you she watches comedy TV shows and movies and spends time with her parents and she knits. She reports she tries not to leave the house because she's often very jumpy, and she says, because of what happened to me. When you ask her for more information, she shuts down completely, she hurries to end the visit, and you make no med changes. A month later, you revisit last month's discussion, and she ends up revealing a long history of sexual abuse from her childhood and one instance of assault in her 20s. She says the world outside isn't safe, and I'm never safe. And she endorses nightmares every night. What symptoms is she having? So if we think about those criteria again. I'm sorry, what? Avoidance, because she's not going outside. Mm-hmm. What else? Hyperarousal, because what? Because she gets jumpy when she goes outside. Yep. What else? Yeah, what are the intrusive symptoms? Nightmares. I think those were all the ones I was thinking of, too. Okay. Well, and we know she has criterion A, too, right? So the actual trauma that she tells us about. And, oh, yeah, there's one other one. The negative cognition mood. And so if you remember, in order to have a diagnosis of PTSD, you actually have to have all of those symptoms. So somebody has to have A through E. Okay, so treatment options. So psychotherapy is a massive part of dealing with PTSD. Pharmacotherapy is one thing, and it does help some symptoms, but it is not the major piece of the pie. Psychotherapy is the majority of treatment for PTSD. We're not going to get into crazy detail about it, but there's cognitive processing therapy, which is very similar to CBT. It's just more focused for people with PTSD. And prolonged exposure, which they do prolonged exposure in other types of psychiatric illnesses. Panic attacks is a common one where they do prolonged exposure, but also like other types of phobias, they'll do certain types of prolonged exposure. So because you see a lot of things where people end up being kind of stuck in their houses, they kind of develop what's called like agoraphobic symptoms, where they're not going outside, they're afraid to do certain things. We have to do a certain element of exposure with them. We also do an exposure to them in regards to their memories of the event. So a lot of times, like what the guy who says, don't talk to me about that stuff, I don't watch war movies, I don't watch the news, I don't do anything. I don't want to be reminded of what happened in Vietnam. Well, what we find is that if we actually expose people more to their memory of the event that happened, they start to have, it has less power over them. We kind of desensitize them to the power of that event. And they start thinking more of like, that's maybe just something terrible that happened to me before, as opposed to the worst thing that ever happened to me, and it's the reason why I can't do anything and function at all in life anymore. So when it comes to medications, we have quite a few options, but there are certain options that are better than others. So first we'll talk about the antidepressants. So there have been studies in sertraline and paroxetine, both SSRIs. Those were the first ones that were ever studied in PTSD, and they had decent positive results, so we use them. Both of those have been approved for the treatment of PTSD by the FDA. We find that SSRIs tend to be better for people who have civilian PTSD. So this is PTSD not associated with any sort of military service. They have used SSRIs in a couple studies in military veterans, and found that only about 20% of those studies were actually had positive results. However, most of the studies in people with civilian PTSD had positive results with SSRIs. We see similar effectiveness data for SNRIs and mirtazapine as to the SSRIs. So we're more likely to see positive benefits in people with civilian-related PTSD. And so if you remember, what are some examples of civilian PTSD that you guys remember from the pre-lecture? Assault, yep. What else? An accident, yeah, a motor vehicle accident, definitely. What else? Being a victim of active terror. Seeing somebody else get killed, depending, right? So if you're in the military, that could definitely happen, and that's considered more military PTSD. But maybe if you see it happen in a more civilian context, then that would be civilian PTSD. Yep. So other things like natural disasters and stuff like that also can count. There hasn't been, so they have done studies with bupropion, and they haven't actually found benefit for bupropion for PTSD. And so we try to not use it really at all in people with PTSD. And again, because there is an element of that hyperarousal and that jumpiness with PTSD, we try to avoid things that make people feel more aroused and more jumpy. And like I talked about with bupropion, that tends to have a little bit of a pretty significant activating factor, and that could make people feel more anxious and more on edge if they're starting it when they already have this baseline jumpiness. When it comes to the antidepressants, all of the same stuff that's in the worksheets applies to this stuff, applies to PTSD too. So the doses and the side effects and all of that's all the same. So anticonvulsants. So these ones are a little bit tricky. They're not great. It's thought that there's a kindling effect with PTSD and that people will have certain flare-ups of their PTSD and that it'll get better and then they'll have flare-ups again. And the reason they thought about anticonvulsants for PTSD is that anticonvulsants have this anti-kindling property. However, they studied several anticonvulsants and found that the effectiveness really isn't that great. And we don't see that people actually do that much better when they're on anticonvulsants for PTSD, especially as compared to other more commonly used medications like the antidepressants. So we tend not to use them very much. The reason I include this is, again, one of those trying to empower you guys to feel confident that if you see somebody with PTSD on valproic acid or divalproex, you can say, well, what's that about? Did they have a traumatic brain injury, which is a very good reason to be on an anticonvulsant because they could be at a high seizure risk? Or is it just for PTSD symptoms and maybe it's not actually doing that much for them and it's probably causing them quite a few side effects? All right, so then on to the antipsychotics. So with the antipsychotics, and the label here is atypical, so that's second generation antipsychotics, and we'll talk about that on Monday. There's varying evidence for symptom reduction in PTSD. We have seen that quetiapine could be helpful for the sleep disturbances, so it can help with nightmares and it can help with people being able to stay asleep through the night. However, we definitely see significant risk for the metabolic side effects that happen with the antipsychotics, again, like we'll talk about on Monday, especially if they're continued for a very long term. We see that with antipsychotics, they can be really helpful, though, in people who start. So I've talked with a lot of patients who have PTSD who say that they feel paranoid, that they feel like there's hearing whispers sometimes, or that people are behind them, chasing them, or they're after them. And they know that that's not really happening, but sometimes that worry does come up, and it's very real to them. And when that happens, that can be one of the best indications for starting an antipsychotic, to try to reduce that paranoia and to try to reduce those symptoms. And most patients say that it does pretty much help them quite well. Okay, so another question. What should Philip's treatment plan be given the following information? He's a 20-year-old male just diagnosed with PTSD. His criterion A event involved physical abuse from age 2 through 8. He endorses intrusive thoughts, memories. He spends most of his time at home playing video games. He doesn't like talking to or meeting new people. He endorses guilt and shame. He has difficulty concentrating, and he has jumpiness. So does he have PTSD? Pretty much. I mean, from what we see here, yeah, that looks like it. So what do you think, just in general, what do you think his treatment plan should be? An SSRI and therapy. Yeah, so combining medication with some sort of therapy, that's definitely what I would do. So we have SSRI or SNRI, and then one of the types of therapy, cognitive processing therapy or prolonged exposure. I think that we don't need to get into the why. It's pretty self-explanatory. Any questions on this? Go ahead. That's a really good question. So with PTSD, it's not that people, so like I said, the exposure is not just, right, it's not like that he's afraid of, I don't know, it's not a phobia of spiders or something, which I'm totally terrified of spiders, but they're afraid most of the time of the actual memory itself, and so they'll try to suppress even having that memory come up in their brain. And so a lot of the exposure is exposing them to the memory itself. And so part of prolonged exposure is where you actually will have a report, you'll write out everything that happened as part of your experience, and you'll have to read it every single day. Or you'll record it on a tape recorder, and you'll have to listen to yourself telling that story every single day. And in order to desensitize yourself to the memory. So that's part of the exposure. And then the other part is he spends most of his time at home playing video games. He doesn't like talking to or meeting new people. So he's not going outside very much. So he's probably not, he may have some agoraphobic symptoms. So we need to expose him to the outside world. And so we'll do that where we'll he'll end up ranking the things that he's afraid of and how afraid he is of certain things. And he'll start with things that he's only a little bit afraid of, like maybe just going and standing in the front yard. Maybe he's a little bit afraid of that. And then he'll do that like every day for a week. And then after a week, maybe it starts to not feel so scary anymore. And so then maybe the next day is taking a walk around the block. And so then the next week, he'll do taking a walk around the block. And by the end of that week, he's not so afraid of that anymore. And you'll just keep working up and exposing him to more and more things to get him to start to feel less aroused and less jumpy and feeling unsafe in those situations. Does that help? Make sense? Okay. And then eventually also, so he doesn't like talking to or meeting new people, exposing him to talking to and meeting new people. Like that could be part of his treatment plan. Okay. So benzos are technically a treatment option, although they send chills down my spine when I see them prescribed for PTSD. So the rationale behind benzos is that people with PTSD share a lot of symptoms as people who have anxiety. The symptoms feel the same. And a lot of times people with PTSD, like when I talk to patients, a lot of times they don't know that they have PTSD. They just talk, my anxiety, my anxiety, my anxiety, all the time. And they feel so debilitated by this anxiety. And they're on like whopping doses of benzos. And they're also addicted to opiates. So my patient population is a little bit different. But because it shares such common symptoms and people are saying my anxiety is so debilitating, prescribers are just like, sure, here's your Klonopin, here's your Ativan, and they just keep giving out these prescriptions. In PTSD, there's also thought to be hypoactivity of GABA. So if you remember, GABA is the primary inhibitory neurotransmitter, so it's supposed to slow things down. Well, if GABA is not active enough, then things are inappropriately like sped up and hyperactive, which we see in PTSD. People are hyperactive. So if we give them supplemental GABA activity through benzos, then that kind of corrects that action. They've done one randomized controlled trial. They did it with Xanax or Prazolam. They found absolutely no efficacy for the core symptoms of PTSD, and they found that rebound anxiety was observed. So what happens is that you take the medication, it calms your anxiety, and then when the medication wears off or after, between doses or something, you actually have rebound symptoms that are even worse than the symptoms you had before you started taking the medication. There's been other small studies to show that benzos also are ineffective for the treatment of sleep disturbances and nightmares. So even though benzos make people sleepy and they decrease that time to sleep onset, people may be able to fall asleep, but they're not getting the restorative sleep. Their nightmares are still there. And so everything still feels pretty terrible even when people are on benzos. So benzos are actually relatively contraindicated in PTSD. And if you guys ever come on rotation with me next year, you'll hear me a lot during rounds constantly talking. They call me the benzo Nazi. And I'm constantly telling people, like, well, have you thought about suggesting them tapering their benzos? And so it's a turning into a joke. But it's people are doing a disservice by continuing to prescribe benzos to people with PTSD because they're actually probably making them worse. So then we get into adrenergic modulators, of which there are several. So if we think of adrenergic modulators, start thinking about, okay, norepinephrine, adrenaline, what's going on. And we talked about in the pre-lecture the role of the sympathetic nervous system and norepinephrine in PTSD. And that's where these medications come in. They've done some studies, and they've looked at all of the medications that are on this slide. The alpha-2 adrenergic agonists, clonidine and guanfacine, they've done studies, turned out to be not that great. They've also looked at propranolol. For post-traumatic stress disorder, it's not very good. They've looked at it also for what happens if we give propranolol right after somebody sees a traumatic event, or experiences a traumatic event. So they've given it to like military personnel when they're like out in battle, and then they come back from battle and they give them propranolol. And there's some possible efficacy there, but I haven't seen it go much further beyond that. They've also looked at doxazosin and taurazocin, and they just haven't done very many studies on them, whereas almost all of the studies have been done in prazosin, so that's what we'll spend the majority focusing on. Here's a summary of the other adrenergic modulators that I just told you. They've done studies on and found that they're not that great. So with prazosin, they've studied a pretty wide range of doses. In all of the studies, they found that prazosin consistently reduces the scores on the PTSD symptom questionnaires, that it improves patients' sleep quality, it reduces nightmares. People will say, I don't dream, I don't have nightmares anymore. And people, it's funny because sometimes people are like disturbed by that because they got so used to having really terrible nightmares that they'll just say like, they're just not, I wake up, it's just black. It was like the whole night was just black. And it's very odd for them, but then at the same time they're like, but it's so much nicer because I'm not having these terrifying nightmares or dreams anymore. People say that it improves their overall functioning in general, and it also improves the hyperarousal that they experience. So most of the time we'll start prazosin at bedtime, and we'll start it at a very low dose. I have a titration slide coming up. Very low dose, and then we'll slowly kind of increase it up to a relatively high dose of prazosin. And what we see is that all of these effects, and even though it's taken at night and it has a relatively short half-life, we find that their daytime symptoms also tend to improve quite a bit. And if they don't improve, we can actually add a low daytime dose to get them to improve a bit more. So you remember this adrenaline gauge from the pre-lecture, where people with PTSD are constantly hovering around this yellow, like moderate to high alert region. What happens when we start giving them prazosin is that we're doing that blockade of norepinephrine, and we end up getting them back into the green. So they're back now like regular people without PTSD. So like I said, this is the titration schedule. Nobody follows this to a T, but it's just kind of to give you an idea of you start out at the lowest possible dose you can take, which is 1 milligram at night, and then you slowly will increase up until the person starts getting either lightheaded in the morning or all of their nightmares go away, and then you don't need to increase past that. So adverse effects to consider. With prazosin, we definitely see first dose hypertension or hypotension. And so what happens is somebody takes the medication, they go to bed, and then they wake up and they get right out of bed and they fall down and pass out. That definitely happens. And so we have to be really careful to educate patients not to do that and to expect to feel lightheaded after their first dose. And then get slowly out of bed, make sure they have their hand on the bedpost or on an end table or on a wall, slowly stand up, count to 5 before they start walking, make sure they feel good, and then start walking. Usually after that first dose, the hypotension is fine. They don't experience it again. But we tell them to keep doing that when they get out of bed or when they go from sitting to standing for the first couple weeks, just to make sure that things are really okay. So along with the first dose hypotension goes along with orthostatic dizziness. People also can report nasal congestion. I had a guy once who said, he's like, all my nightmares are gone, I feel so much better, but I can't breathe at night anymore. Like my nose is so stuffed all the time, I can't breathe at night. And we had to stop it, unfortunately, because he couldn't breathe at night. So it was really terrible because the medication was actually working for him. And then, like, sure enough, like all the nightmares came back, and we ended up going to quetiapine, and it helped somewhat, but nothing like the prazosin helped. People also have reported peripheral edema, and then you can get some headaches. And then what kind of goes along with, because prazosin, originally was used as a blood pressure medication, then it became BPH medication, and now it's used for PTSD. You could expect to see some like heart palpitations with the blood pressure lowering and stuff. So I'm going to try to draw this out because we're like really close to the end of lecture, or the end of my slides. So test your knowledge. What would be your first recommendation for someone endorsing flashbacks from war, isolation, is easily startled, and recently started drinking because it helps with his anxiety? Would you do bupropion 150 twice a day, sertraline 25 milligrams daily, clonazepam 1 milligram 3 times a day, gabapentin 3 milligrams 3 times a day, or titrate prazosin? Yeah. Okay. Oh boy. So little more than half of you said sertraline 25 milligrams daily, and a little less than half said prazosin titration. So for those that said sertraline, tell me why. I actually like when this happens, so we get to have a little discussion. Tell me why you said sertraline. % of you said, 20 of you said sertraline. What's that? Because we talked about it before prazosin? Okay. Any other thoughts? Worth a shot? Yeah. Okay. I'm fine with that. That's how I kind of approach everybody. Worth a shot. Any other thoughts on sertraline? Okay. And then for everybody who said prazosin, tell me why you said prazosin. Okay. Yep. Okay. I agree. Go ahead. Shouldn't take an antidepressant with alcohol? Is that what you said? Okay. So, I think I did this as a trick question. Yeah. So I kind of said both. So taking an antidepressant with alcohol is, they say that, but it's not that bad. It's like really not that bad. We don't expect a lot of symptoms to improve if somebody continues to drink. And so there's definitely should be an intervention there of trying to get them to reduce their drinking or stop drinking. So that would be like one part of the treatment plan for this person. I agree with, so sertraline, yes, the dose is definitely low, but this is the first recommendation. I agree that we would definitely want to titrate after this. And so had I included, sertraline 25 milligrams for 1 week and then increase by 25 milligrams every week, then that would definitely be like the best answer here. However, then he also has flashbacks, he's easily startled, so we would expect to see maybe some benefit from prazosin. I think that one of the things that I always think of first when I think of prazosin is nightmares. If the person talks about nightmares, like no matter what, always do prazosin. Pretty much always, unless they have extremely low blood pressure and you're afraid of them getting hypotensive. However, this person didn't report nightmares as one of his most bothersome symptoms. And so you can maybe start with sertraline and then maybe add prazosin in after a little while. So we do start 2 meds at the same time sometimes. However, I don't like to do it very often. And why don't I like to start 2 meds at the same time? I'm sorry, what? Can't tell which one is working? Definitely part of it. There's one other reason. What's that? Yes. So maxing out doses on one before adding on another is definitely something to think about. And that's not what I was thinking, but that's definitely a reasonable consideration. Yeah. Side effects. So if you start 2 meds on Thursday, and then Monday, the patient calls you and they're like, I have a headache, I'm nauseous, I have diarrhea, like all of this stuff is happening. You have no idea which med caused that. We can kind of assume based on the side effects that are supposed to happen with some meds, but we don't really know. And so ideally you want to at least give it like a week before starting another med. So for this person, because they didn't say nightmares first, I would do sertraline, 25 milligrams for 1 week. I'd see them in 1 week, probably start prazosin that next week, and I'd probably also increase their sertraline up to 50. Does that make sense? Okay. Okay. How about a 32-year-old female with difficulty falling and staying asleep? She's more irritable than usual. She has difficulty concentrating at work. She feels edgy in crowded places. She gets easily startled, and she endorses commonly feeling concerned about all aspects of work, her family, politics, etc. Would you do bupropion, sertraline, clonazepam, gabapentin, or prazosin titration? So again, we have a little split between sertraline and prazosin, a couple people saying clonazepam and gabapentin. So my first question is, what do you think the diagnosis for this person is? What did you say? Anxiety, right? This looks more like generalized anxiety disorder. This doesn't look like PTSD. So this is when psychiatry gets really tricky, because it's easy for, like, I was just talking about PTSD for 20 minutes. So you guys are like, PTSD, PTSD, PTSD. But the fact of the matter is what we see in the real world is people just come in and they just spew out all these symptoms that they have. And you have to kind of think, okay, of all the things that I just learned, what could this be? And thinking about, well, okay, what are her symptoms actually? And what are the diagnoses that have symptoms that look kind of like these symptoms? And so you think about it, like her symptoms don't really, like maybe some of them, crowded places, being more irritable. Sure, people with PTSD have some of those symptoms. But she's worried about everything, work, her family, politics, everything. So this is more of somebody with generalized anxiety disorder. So knowing that, I would say that the answer should be sertraline. Prazosin has no, I was going to try to like give some sort of discussion to the class, but I don't think that there is a good one. Prazosin doesn't have any use in any other psychiatric illness other than PTSD. So we wouldn't expect to see much improvement in any sort of anxiety symptoms, certainly not in mood or anything like that. Okay. Thought I had one more thing. So just to recap, for medication treatment options, if somebody has prominent sleep disruption and nightmares, you of course want to start prazosin. Like I said, just like kind of equate. Nightmares means prazosin. Prazosin means nightmares. Just let those go hand in hand for you. And then you could do with or without antidepressants. And then if they're like having a lot of those paranoid symptoms or something, you might want to do quetiapine. However, if somebody is mostly talking about depressive symptoms and they're having a lot of that, they're filling a lot of that criterion D, which is the negative cognition and mood, and maybe they have a lot of irritability, you definitely want to make sure that an SSRI or an SNRI is part of their treatment. And then you may or may not want to add prazosin depending on their jumpiness and nightmares. And this is another one where, so you can see that both of these treatment options kind of look pretty similar, but just remember, prazosin, nightmares, nightmares, prazosin. And if somebody's really talking a lot about depression and depressed mood, think more antidepressant first, and then prazosin or quetiapine a little bit later. Think quetiapine if somebody's reporting a lot more symptoms of paranoia, feeling like somebody's following them, feeling like they're hearing whispers. So we're back to Dana now, and it's a month later. Oh yeah, so this is what happened after the thing. So she says, the world isn't safe outside, I'm never safe. She endorses nightmares every night. This is when we said she has PTSD. So you check her labs, they're all within normal limits. And she's already on sertraline 100 milligrams daily and trazodone 50 milligrams as needed every night for sleep. So she tells you her most bothersome symptoms are nightmares and feeling jumpy. Which of the following is the best pharmacologic treatment approach to target these symptoms? So, prazosin 1 milligram every night, titrated to 10 milligrams every night if tolerated, and increase sertraline to 150 by mouth daily. Prazosin 1 milligram every night and quetiapine 25 milligrams 3 times a day as needed for anxiety. Prazosin 5 milligrams every night and increase sertraline to 200 milligrams daily. Or clonazepam 1 milligram 3 times a day as needed for anxiety. So most of the class said A, which is the prazosin titration up to a maximum of 10 milligrams at night, which is the maximum for females, and then increase the sertraline to see if we can optimize the dose further. And I would agree with that. Any questions on this or any confusion? Yeah. Any thoughts about that before I come up with a response? So she already takes sertraline 100. So we would expect to know what other kinds of side effects she's going to have. We wouldn't expect to see a huge jump in side effects from going from 100 to 150 because she's already tolerating a decent dose. And usually we don't see a huge jump in side effects from 100 to 150. So it's pretty safe for us to say it's okay to just go up to 150. Good question, though. And then starting the prazosin, because she's feeling jumpy and she says nightmares are her big problem, then we would definitely want to address those too. But because the world isn't safe, I'm unsafe, and everything's because of what happened to me, it's probably a good idea for us to try to target some of that too. So combining those together. Mm-hmm. You can make an argument for either. Yeah, so that's kind of the beauty and the really annoying part of psychiatry, is that you can really make the argument for either. So this is one of those things where, and the other thing to really remember when you guys are taking quizzes and tests that I make up, is when it comes to psychiatry, it's really important to think about what's the best answer of the choices that I have. So it makes perfect, yes, I totally agree with you that we could do sertraline 100 and start prazosin. Like, absolutely, that's not a wrong treatment plan, but it's not one of the 4 options. So that's the other thing to think about. And so what I'll try to do when I'm making the quizzes and tests is make sure that there's one clear option of the 4 that are the best. It's definitely not the only answer. And that's the thing to always remember with psychiatry, is there very rarely is just one answer. And so it's just kind of figuring out, well, which one of these looks like it makes the most sense or is the best of the options that I have. So that concludes the lecture. We ended pretty early. Does anybody have any questions? Yeah. Pretty paranoid, you felt? Yeah. So when I say paranoid, when patients typically talk about feeling paranoid, it's more of like somebody's coming after me, or like people are following me, that kind of thing. Yes, exactly. It's almost like a paranoid delusion that they're starting to develop, as opposed to feeling like the world isn't safe. The world isn't safe is like almost everybody with PTSD feels like the world isn't safe. So that's a very common thing for them to say. And that's more getting after the like negative mood and depression that comes along with PTSD. Does that make sense? Okay.